Look at the strip. The top line is the baby's heart rate. The bottom line is the mother's contractions. The mother is comfortable between contractions. Her blood pressure is fine. But watch the baby's heart rate. Every time a contraction builds, the heart rate sags. And it doesn't recover until well after the contraction is over. The mother feels fine. The strip is telling you the baby does not. That pattern is called a late deceleration, and knowing it, and knowing what to do in the next 60 seconds, is the difference between a good outcome and a bad one. By the end of this, you will read a fetal monitor strip, run an intrauterine resuscitation, tell a placenta previa from an abruption, catch a postpartum hemorrhage, and score a newborn. This is maternal and newborn nursing. All of it. Let's build it from the ground up. Chapter 1. 2 patients, 1 body. Here is the one idea that changes how you think about everything in this course. From the moment of that positive test, you are never caring for 1 patient. You are caring for 2, the mother and the baby, sharing 1 body, connected by 1 organ, the placenta. And almost every decision balances the 2. A drug that helps the mother may cross to the baby. A position that comforts the mother may compress the cord. So the question is never just, how is she? It is always, how are they both? 2 patients. Always. Pregnancy is not a disease, but it changes nearly every system, and a few changes matter enormously. Blood volume rises by almost half, which is why a healthy pregnant woman can lose a surprising amount of blood at delivery before her vital signs move, and why, when they finally do move, she may already be in trouble. The heart works harder. The growing uterus presses on the big vein when she lies flat on her back, which can drop her blood pressure and the baby's oxygen, so we tilt her to the left. Remember those 3. Big blood volume, a working heart, and never flat on the back. 2 pieces of vocabulary you will use constantly. First, dating. Pregnancy is counted in weeks from the last period, about 40 weeks total, in 3 trimesters. Term is 37 weeks and beyond. And second, the obstetric history, captured in 5 letters, G, T, P, A, L. G, the total number of pregnancies. T, births at term. P, preterm births. A, abortions or miscarriages. And L, living children. It is shorthand every nurse reads at a glance. Our patient is Nadia, 30, expecting her first baby, full term, and in early labor tonight. Right now, mother and baby both look well. But she is 2 patients, and over the next chapters, her baby will test whether we can read the strip in time. First, the prenatal watch that got her here safely. Chapter 2, the prenatal watch. The condition that dominates the prenatal chapter and the exam is preeclampsia. After 20 weeks, the mother develops high blood pressure and protein in her urine. The deep problem is that her blood vessels are clamped down and leaky all over the body, and that shows up as the classic triad you watch for. Rising blood pressure, swelling, especially of the face and hands, and the danger signs that mean the brain is being affected, a pounding headache, visual changes like spots or blurring, and pain in the upper right belly. Those 3 symptoms are not complaints to note. They are warnings that a seizure, eclampsia, may be coming. So for severe preeclampsia, the treatment is magnesium sulfate, and it is not for the blood pressure. Magnesium is given to prevent seizures. But magnesium in excess is itself dangerous, so you monitor for toxicity, and the signs come in an order you must know. First, the deep tendon reflexes disappear. The loss of reflexes is your earliest warning. Then breathing slows. Then urine output falls, and because magnesium leaves through the kidneys, low output lets it climb higher. If toxicity develops, you stop the infusion, and the antidote is calcium gluconate. Reflexes, respirations, and urine output, those are what you watch, every hour. 2 more of the prenatal watch. Gestational diabetes, high blood sugar that appears in pregnancy, screened for around 24 to 28 weeks. It is controlled with diet, activity, and insulin if needed. And it matters because too much sugar grows a very large baby, which makes for a hard delivery. And the routine but crucial watches, blood pressure and weight at every visit. And the mother's own report of the baby's movements. A baby that has stopped moving is a reason to be seen today. Pause. A woman with severe preeclampsia is receiving magnesium sulfate. On your assessment, her deep tendon reflexes are now absent, her respirations are 10 a minute, and her urine output has dropped. What is happening, and what do you do? Stop the magnesium infusion and prepare calcium gluconate, the antidote. Absent reflexes, a respiratory rate of 10, and a falling urine output are the textbook progression of magnesium toxicity, in order. Reflexes go first. The magnesium is meant to prevent seizures, but at this level it is depressing her breathing, and you protect her airway and breathing first. Giving the next scheduled dose would be dangerous. The absent reflexes were the early warning, and you caught it. Nadia's pregnancy has been smooth, her blood pressure normal, no protein, no preeclampsia. She is not on magnesium. But she is in labor now, on the monitor, and that monitor is about to become the most important thing in the room. Chapter 3. Reading the strip. The fetal monitor is 2 tracings. The top is the baby's heart rate, the bottom is the contractions. And you read the baby's heart rate in 3 steps. First, the baseline, the average rate, normally 110 to 160 beats per minute. Second, variability, the little jitter in the line. And here is the counterintuitive part, that jitter is good. Moderate variability means a well-oxygenated baby with a healthy nervous system. A flat, smooth line is worrying. And third, accelerations, brief jumps up in the rate, which are reassuring, a sign of a healthy baby. Then you look at the dips, the decelerations, and there is one memory hook that carries the whole thing, VEAL CHOP. Line up 2 columns, VEAL and CHOP. The variable deceleration is caused by C, cord compression. E, early deceleration, is caused by H, head compression, and it is harmless. A, acceleration, means oh, okay, all is well. And L, late deceleration, is caused by P, a placenta problem. So of the 4, early and accelerations are fine. Variable means check the cord. And late is the one that means the placenta is not delivering enough oxygen. Learn which is which, and the strip stops being a mystery. Nadia's strip looks good, a baseline of 140, moderate variability, the occasional acceleration. A reassuring tracing. Keep that picture in mind, because in the next chapter, it changes. Chapter 4. Decelerations. Now put the shapes next to each other. An early deceleration mirrors the contraction, its lowest point lines up with the contraction's peak, a gentle dip down and back. That is, the baby's head being squeezed, harmless. A variable deceleration is abrupt, a sharp V or U shape that can happen any time, tied to nothing. That is, the cord being compressed. And a late deceleration is the dangerous one, it looks smooth and shallow like an early. But it is shifted to the right, it begins after the contraction starts and does not recover until after the contraction ends. That lag is the fingerprint of a placenta that cannot keep up. Early mirrors. Variable is abrupt. Late is late. So when you see a late deceleration or a deep variable, you do not wait, you begin intrauterine resuscitation, and the steps are worth memorizing as a bundle. Reposition the mother onto her side to take the weight off the vessels and the cord. Give oxygen by mask. Increase her intravenous fluids to boost blood flow to the placenta. Stop the oxytocin if it is running, because contractions are what stress the baby. And notify the provider. Reposition, oxygen, fluids, stop the pitocin, call. That bundle is the answer to a huge number of exam questions, and to a real baby in real distress. Pause. During labor, after each contraction, the baby's heart rate falls to 100, and recovers only after the contraction ends. The mother's vital signs are normal. What is this pattern, and what do you do first? This is a late deceleration, and it means uteroplacental insufficiency. The placenta is not delivering enough oxygen during contractions. You begin intrauterine resuscitation immediately. Turn her onto her side, give oxygen, increase the intravenous fluids, and stop the oxytocin, then notify the provider. The single most important first action is to reposition her and take the stress off, while you get help. A late deceleration is never something you simply document and watch. On Nadia's strip, after a strong contraction, the baby's heart rate sags and is slow to come back, a late deceleration. This is her crisis. You begin the bundle, onto her side, oxygen, fluids, stop the oxytocin, call. And the strip recovers. You read it in time. Chapter 5. Labor. Labor comes in stages. The first stage is the longest, the cervix thinning out and opening from closed to fully open, 10 centimeters. It has a slow early phase, and an intense transition near the end. The second stage is the pushing, from fully dilated to the birth of the baby. The third stage is the delivery of the placenta, usually within a half hour. And the fourth stage is the first hours after, when you watch the mother closely for bleeding. When do you go to the hospital? A useful rule for contractions, 5 minutes apart, each lasting a minute, for 1 hour. Or sooner if the water breaks or bleeding starts. When the water breaks, the rupture of membranes, you have one reflex that must fire immediately. Check the fetal heart rate. Because when the fluid gushes out, the cord can be swept down ahead of the baby and get compressed. And the first sign is the baby's heart rate dropping. You also note the fluid. It should be clear. Green-stained fluid means the baby passed stool in the womb, meconium, which can be a sign of stress and means the delivery team watches the newborn's breathing closely. So, membranes rupture, you check the heart rate, and you look at the fluid. With the oxytocin off and Nadia on her side, the baby settles, and her labor moves on, her cervix opening steadily toward 10 centimeters. She is heading for delivery. But first, the complications that can turn a labor in an instant. Chapter 6. When labor turns. Third trimester bleeding is an emergency, and 2 causes sit side by side on every exam. Placenta previa is a placenta that has implanted low, covering the opening of the cervix. Its bleeding is painless and bright red, and the one rule that saves the baby: no vaginal exams, because a finger can tear that placenta and cause a torrent. Placental abruption is the opposite, the placenta tearing away from the wall early. Its bleeding is painful, with a rigid, board-like, tender uterus, and the blood may be dark, or even hidden behind the placenta with little showing outside. Previa, painless and covering the door; abruption, painful and tearing away. And the true obstetric emergency, cord prolapse, when the umbilical cord slips down below the baby and gets compressed against the pelvis, cutting off the baby's oxygen. You may see a loop of cord, or the heart rate suddenly plummets. What you do in the next moments is life-saving, and it is tested word for word. You do not push the cord back in. You call for help, and you use a gloved hand to lift the baby's presenting part up off the cord. And you put the mother in a knee chest or deep head down position to let gravity help, until the baby can be delivered, usually by immediate cesarean. Pause. The membranes rupture with a gush of fluid, and the baby's heart rate suddenly drops into the 70s. You feel a loop of something in the vagina. What is happening, and what are your first actions? This is a prolapsed cord, and it is an emergency. Your first actions: call for help, and with a gloved hand, lift the presenting part off the cord to relieve the compression, while placing her knee chest or in a steep head-down position. You keep your hand there. What you never do is try to push the cord back inside. Everything is aimed at keeping the baby oxygenated until an immediate cesarean. The dropping heart rate right after the gush of fluid was the tell. Nadia has no previa, no abruption, and no prolapsed cord. Her membranes ruptured with clear fluid and a stable heart rate. She has been lucky and well cared for. Now, the delivery itself. Chapter 7. Pain and delivery. For pain, the epidural is the mainstay, medication placed near the nerves of the lower spine that numbs the mother from the belly down while she stays awake. The complication you watch for is predictable: it can drop her blood pressure. And when her pressure falls, so does blood flow to the placenta and the baby. So, before an epidural, you give a bolus of intravenous fluid, and after, if her pressure drops, you turn her onto her side and increase fluids. A falling blood pressure after an epidural is a two-patient problem, hers and the baby's, and you treat it fast. When a vaginal birth is not safe or not possible, or when a baby is in distress that will not resolve, delivery is by cesarean, surgery through the abdomen and uterus. It is major surgery, so the mother afterward is a surgical patient. You watch the incision, her pain, and her ability to move, and a postpartum patient, you watch her uterus and her bleeding at the same time. Two sets of concerns in one person. Which is the theme of the next chapter, because once the baby is out, the mother's biggest risk is just beginning. Nadia chooses an epidural, her blood pressure is watched and holds, and she pushes her baby out. Mother and baby, both stable. But the moment the placenta delivers, the clock starts on her single biggest risk. Chapter 8. Postpartum. After the placenta delivers, it leaves a raw, open wound on the inside of the uterus, and one thing stops it from bleeding: the muscle of the uterus clamping down tight. So the single most important postpartum assessment is the fundus, the top of the uterus, felt through the belly. It should be firm, like a grapefruit, and in the midline. If it is firm and midline, the muscle is doing its job. If it is soft and squishy, boggy, the muscle has relaxed and she is bleeding. And if it is displaced up and to the side, usually a full bladder is pushing it and preventing it from clamping down. That is postpartum hemorrhage, the leading cause of maternal death, and the #1 cause is that boggy, relaxed uterus. So the first action when you feel a boggy fundus is immediate: you massage it, firmly, until it tightens up. If massage alone does not work, have her empty her bladder, and give the uterus tightening medications, oxytocin first. Remember the blood volume from Chapter 1, she can lose a great deal before her vital signs move, so you do not wait for the blood pressure to fall. Firm fundus, no worry. Boggy fundus, massage now. Pause. 2 hours after delivery, the mother's fundus is soft and boggy, displaced up and to the right, and her pad is soaked with blood. What is happening, and what is your first action? Fundus is boggy and displaced, and the lochia is heavy. This is beginning postpartum hemorrhage. Your very first action is to massage the fundus until it firms up. Because it is also displaced to the side, you help her empty her bladder. A full bladder keeps the uterus from clamping down. If it stays boggy, oxytocin and the other uterotonics come next. Massage is first because the boggy muscle is the cause, and firming it is what stops the bleeding. You check Nadia's fundus and it is firm and midline, and her bleeding is normal. The muscle is doing its job. She is not hemorrhaging. Reassuring, because you know exactly what a boggy one would have meant. Now, her second patient. Chapter 9. The newborn. The baby is out. Now there are 2 patients in 2 beds, and the newborn gets its own scoring, the APGAR, done at 1 minute and 5 minutes of life. 5 signs, each scored 0, 1, or 2, for a total out of 10. Appearance, the color. Pulse, the heart rate, and above 100 earns the full 2. Grimace, the reflex response to stimulation. Activity, the muscle tone. And respiration, the breathing and cry. 7 to 10 is reassuring. 4 to 6 means the baby needs some help, stimulation and oxygen. And under 4 needs active resuscitation. The APGAR does not predict the future, it tells you how the baby is transitioning right now. The newborn's whole task in the first minutes is to transition, to switch from being oxygenated by the placenta to breathing air. 2 priorities dominate. Breathing, you keep the airway clear and dry and stimulate the baby, because drying and rubbing is itself a signal to breathe. And warmth, a newborn loses heat terribly fast, and getting cold makes everything worse, so you dry them immediately, put them skin to skin or under a warmer, and cover the head. Airway and temperature. Keep them breathing and keep them warm. Few normal newborn findings that reassure you the nervous system is intact. The rooting reflex, stroke the cheek and the baby turns toward it to feed. The sucking and grasp reflexes. The moro, or startle reflex, a symmetric fling of the arms when startled. And the soft spots on the head, the fontanelles, which should be soft and flat. A sunken one suggests dehydration, a bulging one suggests pressure. These reflexes are supposed to be there, their presence is good news. Nadia's baby cried within seconds, pink and vigorous, a strong APGAR at 1 minute and again at 5. 2 patients, both well. Because at every step, someone was thinking in twos, and reading the strip. Chapter 10. Put it together. Every maternal decision runs through the same 6 questions the next generation NCLEX is built on, with one twist: you ask them for 2 patients. What is happening for the mother and the baby? Why? Which cue matters most? And in maternity, it is often the fetal heart rate or the mother's bleeding. What could I do? What do I do first? And did it work? Think in 2 patients, and read the strip, and you can walk into any of these. Back to the very first strip, the one from the cold open. A laboring mother, comfortable, normal blood pressure. But the baby's heart rate sags after every contraction and is slow to recover. You had no name for it then. Take a moment now. What is the pattern? What is causing it? And what do you do first? Walk it. The pattern is a late deceleration. The dip is shifted after the contraction and recovers late. The cause is uteroplacental insufficiency. The placenta cannot deliver enough oxygen while the uterus squeezes. And what you do first is the bundle: turn her onto her side, oxygen by mask, increase the fluids, stop the oxytocin, and call the provider. You are treating 2 patients with 1 set of hands, and a strip told you before anything else did. If you keep 5 things from this course, keep these. 1. You always have 2 patients, and you never let the mother lie flat on her back. 2. On the strip, variable is the cord, early is the head and fine, and late is the placenta and dangerous, VEAL CHOP. 3. For a late deceleration, the bundle, side lying, oxygen, fluids, stop the pitocin, call. 4. On magnesium, watch reflexes, respirations, and urine output, and the antidote is calcium gluconate. 5. The number 1 cause of postpartum hemorrhage is a boggy uterus, and the first action is to massage it. Pause. At 1 minute of life, a newborn has a heart rate of 90, a weak grimace, some flexion of the limbs, a slow weak cry, and a pink body with blue hands and feet. Add up the APGAR, and say what you do. At 1 minute, add it up. Heart rate below 100, that is 1. A weak grimace, 1. Some flexion, 1. A slow, weak cry, 1. And a body that is pink with blue hands and feet, 1. That totals 5, which falls in the middle range. The baby needs help. So you act on the 2 priorities: stimulate and clear the airway to get the breathing going. And keep the baby warm, then you score again at 5 minutes to see if it worked. A 5 is not a verdict, it is a to-do list. That is maternal and newborn nursing. Not 1 patient, but 2. Sharing 1 body and 1 strip that tells you how they are both doing. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who reads the strip and knows what to do in the next 60 seconds.